Hello, I'm Professor Dylan Ritchie here at Aspen University. This is N310A, Fundamentals of Nursing 1, and today we're going to dive right in to Module 2, which is going to focus on activity, immobility, and safe movement. Oftentimes, we will hear this referred to as safe patient handling, but safe movement also would be an appropriate term. Diving right in because we have a lot to get into today. Let's start at a high level overview of the normal structure and function of movement for the human body. So we can look at some umbrella terms at a higher level here and talk about the musculoskeletal system. Obviously, we would have covered a lot of this in your anatomy and physiology, but really, for the intents of this lecture and more or less this conversation, the musculoskeletal system is really what's going to set up that framework of movement throughout the body. And what you see here captured is figure actually 28.1 from your textbook, and that is the correct upright body alignment. When we look at the nervous system, think of all those electrical impulses, those electrical controls. It's more or less the motherboard of the body, whereas the musculoskeletal system is the physical framework for movement. The nervous system is what controls the movement. It controls our balance. It controls how gait occurs with the body, gait or referred to ambulation, how the body moves. Is it symmetrical, the way the body operates? All of that is made up of the musculoskeletal system and the nervous system functioning together. And then finally, the cardiopulmonary system is what's going to actually exchange and send nutrients and oxygen throughout the body so that the musculoskeletal and nervous system have the right nutrients and oxygen required to do their job. So it's really a synergistic impact between the musculoskeletal system, the nervous, and cardiopulmonary system. So when things start to go wrong, altered structure or altered function of movement across the body, some musculoskeletal specific issues that we can see is overall bone fragileness or fragility. Maybe the musculoskeletal system, the bone structure, it doesn't have everything it needs, whether it's a nutrient imbalance, various different things where the bones are not strong enough to actually support what the body's designed to do. That could really cue in on some things that we're going to look at as nurses. How would we maybe notice musculoskeletal system issues? Well, that bone flaccidity or being flaccid, maybe they cannot use a particular area of our body. They are totally flaccid. They have no control. Often you'll hear the phrase, kind of the slang of dead weight. It's flaccid. Maybe it's an arm. Maybe it's an entire portion of the body. Hypotonicity, hypo, so less than, it's a state of abnormally low muscle tone. So these bodies, when we see these, whether it's an entire body system or maybe it's an extremity, potentially there was an issue in perfusion, a stroke, that impacted part of the body. You'll see in the geriatric population, they might actually have one leg. The stroke affected leg has less muscle tone than the leg right next to it that is still fully functioning. That's just an example where you'll see hypotonicity. You can physically see, you can physically assess with your eyes as the nurse, abnormally low muscle tone. In the nervous system, when things go wrong, you in the nervous system, when things go wrong, you'll note that you might have things such as hemiplegia, which is a paralysis of an entire half of the body. You could note paraplegia. Paraplegia, these get a little complicated based on that base word, right? So paraplegia is going to be a paralysis strictly of the lower extremities. So a paraplegic would be someone that does not have full operation of their legs. And finally, another nervous system telltale sign that obviously something's going on. We can physically assess as nurses, and our scope would be a quadriplegia, which will be a paralysis of both arms and both legs. Quadriplegic or quadriplegia is what we would know. Let's look at the cardiopulmonary system and switch gears. So when we see and we assess things from a nurse, we'll note compromised cardiac function. We may know because of that we have a a decreased, tissue perfusion. And we can note with, when we auscultate with our stethoscopes and we're doing our whole body assessment, we'll notice that we hear diminished lung sounds or decreased respiratory capacity. These are all things that, for our patient population with altered structure and overall functional movement of the body, these are things as nurses that we'll pick up on and see out in the field. So kind of in focusing in and honing in on immobility. So when we're doing assessment, things that we'll see out regardless of the patient population that we're taking care of, you would be able to note things such as weakness, that may be a focused area weakness, maybe generalized weakness. It really depends on what's going on with the musculoskeletal system. You will know and be able to see decreased muscle tone. So again, that hypotonicity. For your big bodybuilders and the big Arnold Schwarzenegger characters, you might notice hypertonicity, massive muscle structures. That might be something that was intended, or, again, there might be something going on there if it's just localized. We might note decreased bone and muscle mass. Again, kind of just looking at the body, slightly subjective, but we can note, especially if one part of the body is different and it's not symmetrical, if one leg is different than another, or when comparing hands, fingers, other extremities. We can note muscle atrophy. Muscle atrophy with effects on the body, really, you'll note that the body will actually recognize, hey, we're not using this muscle, and that muscle is a part of the body. The body will break down that area, atrophy that muscle because it's not using it, and actually take those parts of the body and allocate them elsewhere. The brain and the body are very smart, and they will put those resources where they're best fit if an area is no longer being used of the body. And that thought, this photo is a really good example of a contracture. A contracture, which you'll see in your book, this is figure 28.2 in your textbook. It's a rigidity of the joints, and due to shortening and hardening of the muscle tone, maybe the tendon and other tissues in the area, because it's not being used, it's no longer a functional part of the body, and it is going to become more and more rigid because it's not being used, and the body's not allocating resources, to make that area functional again. Let's talk about our nursing assessments, specifically on the effects of immobility. So when we look at our nervous system, you have proprioception, which is the awareness and the positioning of the movement of the body. So it sounds really complicated, but really it's just that awareness of the position and movement of the body. That can be altered. Something's going on and they do not have a full awareness of how the body is actually positioning itself or how the body is actually going to move. There's some type of disconnect going on with that nervous system and the electrical impulses it's sending out and how it's perceiving information. The equilibrium, that's the actual physical balance. Does the body have balance? That can be affected if something's going on and we're dealing with a patient that has effects with the nervous system in regards to mobility. Let's focus on that cardiopulmonary system for a little bit. So the body is going to recognize its workload is increased because it's trying to make up for the additional burdens and stress that are going on there. It's trying to get those nutrients and oxygen over to different parts of the body because it's being immobile. We can talk about lung expansion. The demand is not there, and the body could have some stasis going on or being stationary because of, maybe it's a quadriplegic or a paraplegic situation. So the lung expansion is going to actually decrease because of the lack of movement and everything that's going on. The third bullet point there, circulatory stasis. That is meaning the blood is becoming static. It's sitting still. This is when you start thinking about potential impacts, about clots being formed. The blood is not moving. You have pooling of blood in different areas, or the blood is not flowing as quick or actively as what we're used to. So we look at pooled blood and the opportunity for things, bad things like deep vein thrombosis or DVT. That pooling of blood makes a clot, and that clot can't clear the vessels. Well, that's going to cause some problems and may add more immobility. And then we talk about activity intolerance. So the body is static for a very long time. It's not getting a lot of exercise. Well, now we go to ramp it up and get back to what life was like before, or normal activities of daily living. There may be some intolerance there, depending on how long those impacts, were going on. Let's talk about nutrition. How is nutrition effective? Well, our basal metabolic rate, or BMR, that's simply the number of calories that your body needs to perform living. It needs to perform basic life-sustaining functions. It's going to be reduced. The body doesn't need as much to live because it's not doing as much work. Simple as that. Uh, Catabolism, which is that breaking down we were kind of talking about when we were talking about atrophy and the body sending, that muscle and fat, etc., elsewhere in the body to put it to use. That's a process of catabolism, and that's proteins are going to break down and be put elsewhere. So that's going to cause potentially a negative nitrogen balance if the dietary support is not there, if people aren't eating well and taking care, paired with being a static lifestyle. You'll have continued immobility, may lead to anorexia and nausea. Again, the body just doesn't need everything that it was taking in previous, and there are impacts related to that. We talk about elimination. So urinary stasis, you have increased risk, our patients have increased risk of urinary tract infections and renal calculi. So now we're talking renal stones, not fun. Hypomotility, or lack of movement, right? Less than hypo. Less movement has a major impact on our GI tract and how we break down food and eliminate accordingly. So not getting up, short story, not getting up and moving around has a lot of impacts on your actual elimination system. And I think a lot of people take that for granted or don't understand that sometimes. Let's talk about the impacts on the skin. So as nurses, we're always looking at those bony prominences. We're trying to make sure we're not going to get that last point there, pressure injuries. Pressure injuries are a big no-no in nursing and something you really need to keep your eyes on, even for younger, healthy-looking individuals. Once the body has immobility, the skin is very sensitive and can break down even in young folks as well as the elderly if there's any type of long periods of immobility. So what happens is, before we get to a pressure injury, is that bony prominence starts to cut off supply and it causes ischemia. That prolonged ischemia, or lack of oxygenated blood and perfusion, it's going to lead to necrosis. And necrosis, it's that premature death of healthy cells and healthy body tissue. So necrosis is not normal death and recycling of cells like we see in some processes in the body. That necrosis, it's a premature death of good body tissue that is not normal. And that necrosis eventually, over an extended period of time and neglect, will lead to various staged pressure injuries, which you'll talk about a lot in your physical skills and your assessments. Psychosocial impact. So not being mobile has a big impact on people and how they feel. So isolation and sensory deprivation, if it's a hemiplegia, paraplegia situation, these individuals cannot get out and mobilize by themselves without assistive devices or help from others. That has a big impact, especially if it's prolonged, on isolation and sensory deprivation. These individuals may think different about themselves. It really can get people bluntly in using our diagnosis into a depressive state. It's not good for us to be isolated secondary to some type of medical intervention. Like, these people aren't choosing to be isolated. They have some type of disease process or immobility issue that, against their will, is keeping them from going out and socializing. And that can also have impacts on our sleep and rest patterns. It's a big holistic effect on what happens for immobility, secondary to some type of medical event. So let's talk about nursing diagnosis. What will we write in some of our care planning and our nursing diagnosis? You could document impaired mobility, and you can document secondary data such as, let's talk about left-sided weakness. Maybe they have impaired visual self-perception or impaired visual spatial perception. Skipping ahead, we can talk about activity intolerance. So these individuals, we're going to know, hey, we're getting them better. They're in our particular healthcare setting. Well, now we need to plan ahead because the body's been static and resting for a long time. We got to ramp up that activity slowly. And we might note that activity intolerance is something that's going on because that patient has maybe been bedbound or significantly decreased mobility for a period of time based on what they had going on under our care. We can talk about planning. So we're going through our ADPI process, assessment, diagnosis, etc. Now we're on to planning. So we can consider the importance of being each of these identified diagnoses. They all have to be tackled. We got potential psychosocial effects. We have a nervous system issue. We have actual musculoskeletal system. We have to kind of tackle and treat those differently, and they're all important. We need to address the most critical one first, though, when we make out our care plan and decide, hey, which is the priority based on all of these things we're trying to tackle. Everything's important, but we need to prioritize them. We might have to take a collaborative approach, and that's going to be imperative when addressing problems with mobility. You can't tackle it all yourself as the nurse, so you might have to leverage some of your peers. And we need to set short-term and long-term goals so that we can get to the bigger picture, but work it backwards so that the patients understand what can I do today to meet these long-term goals. So we're going to make short-term and long-term goals to help each particular nursing diagnosis we identify. Talking about the musculoskeletal and nervous system and their interventions. What can we implement and evaluate? Well, we can talk about early ambulation. Getting the patient moving as quick as possible is always key. We want to get them up, moving out and about in a safe manner as quick as possible. And there's a lot of studies to show the quicker we can get people up, moving around, ambulating, walking again, getting back to some activity is going to be better. And there's a bunch of different ways we can do that. And this is not an all-inclusive list, but this is just some key vocabulary that you'll hear throughout your entire nursing career. So we can talk about isotonic. Isotonic exercise is really going to break down as far as to help you visualize. Think of exercises where weights are lifted and lowered. So that's really isotonic. So think, squats, leg presses, think of bicep curls, think of push-ups. So we're using those muscles. We are applying the same amount of tension and we're working the muscles that way. Think of isometric as being a little bit different. So isometric are going to be your stationary. You're working out parts of your muscle by holding them firmly. You're not lifting and putting down. You're holding firmly and you're working a core grouping. A lot of time it's core. So think of items such as planks. Someone is up on their elbows and their knees. They are holding still and firm. They're getting a high quality exercise, but they're not moving, the muscles back and forth when compared to an isotonic exercise, such as doing a bicep curl, where we are expanding and contracting the arm. So an example of isotonic, again, would be kind of curls. Isometric, for example you can picture, would be planks. They're not using the muscle and expanding, contracting back and forth in isometric. We're just holding that muscle still and flexing it and getting exercise that way. I hope those are two good visual aids to kind of help you break those apart. I know that can be tricky sometimes. We're talking about different types of exercise from a different lens. So now we're going to talk about the oxygen demand of them. Let's talk about aerobic. Aerobic exercise is usually moderate intensity, maybe a little high intensity, and it's activity that you sustain. Think cardio, running, sprints, rowing machines when we're doing some cardio using the upper body, that is going to increase the demand for the amount of oxygen the body needs right now. So this is cardiorespiratory fitness. Again, popular ones are going to be running, jogging, rowing, things like that. So that's aerobic. We're increasing the demand specifically for oxygen. Anaerobic, so leading with A, so lack of. Anaerobic uh, exercise involves short, high-intensity exercises that don't make your body use oxygen like it does when comparing it to like cardio. So this is more weightlifting, kind of bodybuilding, short periods, high weight, low repetitions, just so we're working and kind of honing in on that muscle group without increasing the demand of oxygen. Active and passive range of motion exercises, so comparing those two. Active would be we're in the gym and we are lifting the weights, we're doing the squats, we are moving that muscle, that body part, that joint, we are actively doing it ourselves. Whereas passive range of motion would be us as the nurse taking care of a patient who has a flaccid arm, and we are guiding the arm, and we are physically doing the range of motion exercise for the patient. The nurse is moving the patient's arm or joint. This can be done in the upper extremity with the wrists, elbow joint, maybe even the shoulder joint. And we'll also see this in the legs, at the ankle, the knee, and hip. So the nurse or the therapist, if it's physical therapy, is doing the actual exercise and movement for the patient. That's passive range of motion exercises. And of course, we always want to look at the patient's tolerance. If pain is going to be in play, we have to treat that, obviously, popularly referred to as a vital sign. We need to think ahead. Maybe if this is a painful intervention, we might look at pre-medicating or doing things ahead of time to prepare that patient for something that might cause them some discomfort. Moving on and looking at implementation and evaluation of the musculoskeletal and nervous system intervention. So positioning devices. We have the opportunity to use pillows. We might use spring or splints and braces, kind of like how you see here in the photo listed. And you might look at hand rolls just to help cause I guess you would say, comfort. It might help with the patient to keep that joint in a functional position. Really, these will be used various different ways, and it really boils down to what's going on with that patient, what's that diagnosis. But you can use these positioning devices across a broad spectrum of diagnosis to help keep that joint in a safe, functional position while also increasing some comfort and making sure our skin integrity. We don't want any bony prominences laying around, and help there. When we look at different things in this photo, you can see trochanter rolls. Those are those rolls, those blue rolls you see in this particular photo, taken directly from the textbook. This is figure 28.7. Those are trochanter rolls, and you see those for positioning and comfort. They're kind of those harder foam rolls that help with repositioning. Log rolling, very popular. If you have a patient that's bedbound or mostly bedbound, it's a good way to get assess the skin. We can look while we're also changing and turning linens. It's a maneuver you will use regularly, not only for patients with ambulatory issues, but patients that have a hard time getting in and out of bed because of other diagnoses. Look at fall prevention. There's a lot of different things. It really is based on your facility and what they allow. Handrails are kind of slowly but surely being phased out of being able to be used. I know some facilities will allow you to have 2 upper head rails as long as both lower head rails are lower. Some allow for 3 rails to be up. Other facilities I've heard may not let you use them much at all. So we look at other interventions, fall preventions. You might have a low bed for patients that regularly fall secondary to disease processes, including altered mental status or impaired mobility. And lastly, we have ambulation aids, which we'll go over significantly more in depth later on, but think of things that help the patient move. Let's talk about transfer belts, often referred to and similar to like a gait belt. So you apply it snugly and you stand on the patient's side, and this is right just above kind of where you will put a belt for your pants, and you hold the gait belt firmly at the back of the patient's waist, and it allows us to provide hands-on support and assistance for patients that have maybe some type of weakness or impaired mobility. Another popular device that we've all seen is the use of a cane, and there is such a wide variety of canes that you will learn about. And there's truly, again, go down to specifically where is the patient at in their life, where are they having issues, what is the diagnosis, and depending on a compounding effect will determine what cane your particular prosthetic service provides for this patient. The patient holds the cane when we're educating them. They actually hold the cane on their strong side. A big no-no that you see sometimes is people think, oh, my left side is weak, I'm going to put my cane over there. No, you put the cane, and we educate our patients to put the cane on the stronger side. Then they advance the cane first, then the weak leg, and finally advance the strong leg. So it's kind of a good breakdown that you'll see actually in your textbook in 28.9, the use of canes. Crutches, along the same thought of canes, but crutches. We have the forearm cane, which you see here actually in figure B. So the bottom right photo is what you see for the forearm cane. These are more long-term cane usage. What you see in figure A, so the photo on the left, the gentleman in the red shirt, is a more standard crutch that is okay for short periods of time, but if we know this individual is going to use a cane pretty much for the rest of their life daily, we often refer to these longer, they're a little more expensive, but much more comfortable, and they deal and they prevent a lot of issues that can come with extended use of the underarm cane. There's a lot of issues that can pop up from that based on what you have going on in your arm area. And there's different gait points. So there's the 2-point, and the 3-point, and the 4-point gait system. You'll see in your textbook there's a good visual aid in 28.10 that goes over this, but the points are strictly the amount of time something is striking the ground, if you think about that. So your 2-point gait and your 3-point gait and your 4-point gait is how you're advancing the crutches. The 2-point gait is when you see kind of that swing through motion. They put both crutches down and then swing their one good leg forward. That's 2-point. 3-point is when we advance both crutches forward, and then we take one extremity followed by the last leg forward. So think about it. You have 3 strikes. You have the 2 canes. There's one leg, then the second leg. So that's a 3-point gait. And finally, a 4-point gait. You advance one crutch. You advance the second crutch. You advance the first leg, and then you advance the second leg. So 2 crutches and 2 legs, all moving independently, one at a time, is going to be that 4-point gait system. Talking about crutches when we're going upstairs, this is something that can really throw patients off if you've never been on crutches before. It's going upstairs and going downstairs are different. So when we are educating our patients to go upstairs, we're going to tell them, you want to transfer the weight from your crutches to the unaffected leg on the stairs. Then we're going to educate the patient to bring up the crutches onto the stair and align them with the affected leg. When we talk about going down the steps, we're going to educate the patient. They're going to transfer their weight from the unaffected leg to the crutch. Then they're going to bring the ineffective leg down onto the stair and align it with the crutches. So a little bit tricky. It's almost backwards, depending on if you're going up or down the steps, on how we're going to educate our patients to use the crutches. We talk about walkers, so another assistive device that is similar to crutches, except for the patient is going to stand within the walker, like you see here in this figure. Crutches, we're almost using them and they're attached directly to the arms. With a walker, we're using our hands instead of our underarms or our forearms to kind of guide the area. And the patient can lift the walker one step, plant the walker on the ground, and then advance their two legs into the walker. So a little bit different motion, nonetheless, we're all ambulating. The 3-point crutch walk is when the patient lifts the walker one step and then slowly advances one leg at a time back into the walker. They'll pick it up again and then slowly advance one leg at a time. We talk about mechanical lifts. These are going to be always preferred. If we can use a mechanical system to help us versus using our back, our muscles, our musculoskeletal system as the nurse, we're always going to use the mechanical lift first. Take your time. A little bit of guidance for everyone out there, especially starting as a nursing aide and then becoming a nurse. It adds up quick. If you have the opportunity to take a little bit longer, but use an assistive mechanical device to save your back as the nurse, take your time and go ahead and use that. Because it's going to allow for you to protect your body from that long day that you're working, taking care of a bunch of different patients, while also it keeps that patient actually in a safer position. The mechanical lift is much less likely to fail them if used properly than the likelihood of us having human error. We are not positioning ourselves well. If we lose our balance or if we lose our positioning with the patient, well, there's the opportunity for two people to get hurt, right? You have the patient potentially falling and getting hurt, as well as the nurse can get hurt by falling or throwing their back out, etc. I'll get off my soapbox. Some lifts can also be used for ambulation, so use it per your facility's instructions, as well as the education that you get for each piece of equipment, but there is lifting equipment that also can be used to help with ambulation and ambulation practice, again, depending on what that patient has going on. Patients can be placed in the harness. They can be lifted until their feet are off the ground. Patients can have the opportunity, depending on the lift and the pad that's with it, they have the opportunity to increase the stability and they can hold on to the lift or device themselves. And the entire time this is going on, again, the nurse is not holding any weight. The lift is supporting the patient's weight. We're using our lift and our mind to do the rest of the work, while the lift is actually physically lifting all of that weight. So protecting our bodies, but still giving therapeutic intervention to the patient. With safe patient equipment, again, we have lift equipment. So lift equipment is going to maximize patient's assistance while drastically decreasing the risk of injury to the nurse. Same thought. This lift equipment is physically lifting the patient for us. And for patients that are on bed rest, we can have them help, and this is in combination, maybe with a lift. Otherwise, if this is just the patient and the nurse, there's equipment we can use that's attached to the bed. So the two common ones you'll see where you as the nurse can instruct the patient to assist with the lift and help, take on some of that patient's body weight while we do the rest of the work. Think the two top side rails. Often they have multiple grab bars where patients that have full range of motion in their upper extremities can reach up, grab, and pull and help take some of the weight when we are assisting and repositioning them. Others, you don't see these as much as you used to, but you do see intermittently the use of a trapeze, and that's where you often have above the head the bar, the different grab bars, often a triangle where a patient can reach up, grab both, and pull a portion of their body weight and assist in repositioning. That way the nurse or the aide are not doing all of the physical lift. When we're focusing on implementation and evaluation, now specifically honing in on that cardiopulmonary system, some of the interventions that we can do with the cardiopulmonary system would include, if the patient allows for it, we can raise the head of the bed and really promote lung expansion. Give those lungs the proper positioning and to actually expand and allow more oxygenation to occur within the body per breath. We can teach them routine coughing exercises and deep breathing exercises. So think like the popular one, the incentive spirometer, right? We can utilize interventions such as the incentive spirometer to make up for the fact that that patient is immobile or in bed much longer than what they're normally used to, and prevent some secondary impacts with the lungs that comes with being static for an extended period of time. And then turning and repositioning, we often take this for granted, but turning and repositioning is very positive for the cardiopulmonary system. We don't want to keep those lungs expanding and contracting in the same way each breath. Preventing DVTs. So thinking back to clots, this patient is immobilized. They're having increased opportunities for that blood to pool and be static, eventually creating a clot. We do not want that to occur. Clots obviously lead to a lot of secondary and can be very quickly, they can really impact a patient and become catastrophic. We might use things to help us with this because the patient is static and in bed. We can apply anti-embolism hose, so those kind of compression socks, compression stockings are often referred to. Those help squeeze the area and not allow as much blood to pool. If the patient's going to be in bed a lot, we might go ahead and get some sequential compression devices and recommend for that to be ordered by the provider. So the SEDs, sequential compression devices, are those alternating, squeezing, air controlled, and they're squeezing and expanding and contracting and forcing the blood to recirculate, decreasing the likelihood we have some type of clot form. And of course, we want to avoid placing pressure on those lower extremities. We don't want to put anything on top that's just going to squeeze multiple layers of blankets, or setting something down and letting it stay on a patient's lower extremities for an extended period of time. Thinking circulation, that pressure is going to decrease circulation and increase the chance that blood starts to pool, creating a clot. We can think of increasing that early ambulation. As soon as we can get a patient out of bed and working towards those ADLs again, the better. Hands down, every single time, so long as that it's done safe. Obviously, we're not trying to rush people out of bed, but the second we have the green light from the entire disciplinary team to get that patient up, every single chance we can, or we have time, we want to get that patient up and moving about. It's just across the board, the evidence shows better outcomes the sooner we can get patients moving again. We need to remember this is frustrating for that patient. They did not choose to be here. So we want to be patient at the same time. So we're going to be encouraging and we're going to be pushing to get that activity up. But we also need to remember to be patient while participating in those ADLs, because the patient's going to naturally experience some frustration and maybe some discomfort and pain. And always dangle the patient's legs before standing. Let them dangle their legs off the edge of the bed like you see in this photo. Let them sit. We don't want to get a patient from a completely laying flat on their back to standing straight up. Think orthostatic hypotension. We don't want that patient to suddenly experience lightheadedness or bottom out strictly because they just got up too quick. As we get older, this becomes more and more of a priority to remember. Let that patient sit on the edge of the bed, get their balance, get their equilibrium, and then advance to a full standing position while we monitor for any potential orthostatic hypotension. Nutrition interventions. We often take this for granted, so we want to make sure that our patients understand. We want to offer them meals that include lean proteins. We want them to make up for some of those nutritional imbalances we talked about at the very beginning when we were introducing the nutrition impacts of immobility. We want to counteract that and make sure that they're taking in the proper food. We're going to do that by ensuring and offering small, more frequent meals and allow the patient to participate in their dietary choices. Maybe we can offer them a couple options of lean proteins instead of just picking one for the patient. We want to increase that activity as tolerated. So those short-term goals, every day we want to try to do a little bit more so that we can get them to the long-term goal, which will be different for each patient based on what's going on and what their ADL goals are. And lastly, we want to encourage adequate fluid intake. We want to make sure we're taking in good nutrients and lots of fluids. When we look at our implementation and evaluation, focusing on the elimination intervention. So we want to, again, increase that fluid intake, let the body exchange out and keep those kidneys working. We want to encourage positional changes. The elimination system is facilitated by getting up, moving around, allowing that gut to break down food and manually position itself for elimination. We might get this done in via a toileting program. Maybe we get a patient up on a set schedule. Every patient is different on what they can tolerate, but maybe we're getting them up every couple hours and offering them a toileting program so that we can increase those elimination processes. We might have to use things such as bedpans or bedside commodes. This could be because mobility, it doesn't make sense to get them out and about or move across the room to a bathroom. They might have some type of limitations for activity tolerance, or the overall mobility causes increased strain and burden. We can look at early ambulation, again, getting patients up and moving as much as possible. It has a major impact on our elimination processes, especially when we're talking about treating constipation. Activity intolerance and constipation go hand in hand across a wide variety of disease processes, regardless of age. We want to get patients up and moving around because it really does play a big case in constipation. Getting up and moving around, taking in the proper fluids is going to really, really help get in front of that before we go to potential medical intervention because of chronic constipation. Next, we'll talk about our skin interventions. So we can turn immobile patients at least every 2 hours. We are required to turn patients every 2 hours, moving those bony prominences around, repositioning, turning the patient to alleviate any potential area for pressure injuries. We want to use pressure relieving potentially devices and pressure reducing mattresses in conjunction with each other if recommended. We need to make sure those bony prominences are again being moved around and avoiding any and every stage pressure ulcer, stage pressure ulcer injury for patients because of immobility and protecting the skin. And we can use heel and elbow protectors, much like you see is the heel protector here, and this is from 28.21 in the book, to avoid skin breakdown. Let's look at psychosocial interventions. How can we encourage the patient to, be in the best mental state, the best overall spiritual state possible, secondary to dealing with immobility? Again, that isolation really has an impact on the patient. Most of these patients are dealing with something that has come on suddenly, and it can be taxing. So we want to encourage them to contact their family and friends. We have obviously phones these days where we can have, whether it's a video call or a phone call, we want to encourage them to still be social. We want to minimize the amount of disruption we have. Easier said than done as nurses, but we want to have the minimal disruption possible for sleep and rest patterns. We want to explain all of the procedures as to why we're doing what we're doing or what we're recommending. We can refer to different community resources and different social resources throughout our facility based on what you have available to you. And then for patients that have maybe some altered mental status, we want to continuously reorient our patients to what's going on, reality, time, place, what's going on, particular events. Lastly, our evaluation. So we're going to evaluate the treatment and intervention for all of our immobilized patients and have limited mobility and confined to bed rest. We want to evaluate and continuously adjust care plans, our nursing care plan goals as needed. We're going to meet some goals we're not going to meet, but we're going to regroup and we're going to make sure the patient's involved and evaluate what we need to do next. We must continually evaluate the effectiveness of our interventions and reference them to the short-term and long-term goals that us in conjunction with the patient have set out. And it may provide the opportunity to reevaluate some goals, maybe goals the patient is going to crush and meet quickly, other goals they might struggle with. So we will reevaluate and constantly fine tune some of those short term goals until we get to the long term goal of getting that patient where they want to be with their activities of daily living, secondary to increased mobility. Thank you.